Sir, you are in live. Good to go.
Okay. So, good evening, everyone. Welcome to this obstructive sleep apnea webinar. And today we are having three talks on sleep apnea. So, initially, I will be speaking about the introduction to sleep apnea and the basics as well as the importance of sleep apnea. And then we are having Dr. Saurav Das, who is a sleep specialist from Kolkata, and he'll be giving about the specific aspects of sleep testing and polysomnography and the other technical aspects about sleep study. And after that, we are having Dr. Uttam Agarwal, who is a ENT surgeon, and again, he practices sleep medicine. So he'll be speaking about the surgical aspect and the other investigations and treatment of difficult to treat sleep apneas. So I will start my talk. It will be a brief talk of around 20 to 20 minutes, 25 minutes. And so I'm sharing my screen. Is it visible?
Yes.
Okay. So in the next 20 minutes, I'll be speaking about the relevance and the importance of obstructive sleep apnea. How important is it in our clinical practice, not only for sleep specialists as well as for general physicians and probably all specialties. So the sleep apnea is not a new disorder. It has been known to the medical fraternity from long. Even we are having articles about sleep apnea right from 1877 in the Lancet, which describes sleep apnea. So this is the classical image of a patient with obstructive sleep apnea, obese and short neck, chubby cheeks, and quite obese with having like plenty of beer and all those things with metabolic syndrome. So that is the typical picture of a obstructive sleep apnea, but it may not be true always, because in the Asian population we see people who are non-obese, who are slim, and yet having some abdominal obesity can develop this sort of sleep apnea syndrome. So we have to have a very high clinical suspicion to suspect as well as diagnose this condition. So what is the epidemiology of sleep apnea? It's a relatively common disorder. The prevalence is around 3% in women and 10% in men, 30 to 50 years. And after 50 years, the prevalence increases almost 3 times in women. It's 9% and it's 17% in men. So probably the menopause and the hormonal factors come into play in ladies. And according to the body mass index, if it BMI more than 30, the prevalence is 40%. And 60% of the patients with metabolic syndrome who satisfy the criteria of metabolic syndrome are having obstructive sleep apnea. Male sex is an important risk factor, and it is seen that it is more prevalent in African Americans in the same age group when compared to that of Caucasians. And in the Asians, the prevalence is more compared to United States, but the obesity is less. Still, the prevalence of sleep apnea is more in Asian population. So it becomes quite important in the Asian subset of people, the prevalence of sleep apnea. Estrogen and progesterone plays a very important role. Progesterone in the younger females are protective and it stimulates the upper airways, thus reduces sleep apnea in the younger age group. And androgen levels may be pro-sleep apneic, and especially people who are taking androgen supplements or ladies with PCOD who are having more androgen levels in the body can have obstructive sleep apnea. Coming to the epidemiology, if you look at this slide, you can see these are the 10 most prevalent countries with obstructive sleep apnea, and you can see India, Pakistan, Bangladesh, China. So these are the prominent countries who are having a very high prevalence of obstructive sleep apnea. So it's a common disorder in the Asian population. Now coming to the sleep, if you look at the cases we see in a sleep clinic, the most important chunk of patients are obstructive sleep apnea, 47%, and insomnia, 45%. So this forms more than 90 to 92% of the patient in sleep clinics are sleep apnea and insomnia, and the rest of the other causes are circadian rhythm disorders, RLS, and so on. Now, we should know that sleep apnea, obstructive sleep apnea is a spectrum disorder. So it ranges from mild forms to very severe forms. So if you look at this, the normal is, you can say, normal upper airway. Then there is something called as primary snoring, or in which the patient just has snoring, but there is no apnea, hypopnea, or respiratory or RERAs, which we call as respiratory related arousals. So they are having just snoring. So this is called as primary snoring. It is diagnosed when the AHI is less than 5 and there is snoring. So that is the most mild variant of this spectrum. Then you are having the upper airway resistance syndrome, in which there is degradation of the sleep, but it does not meet into the criteria of hypopnea or apnea or the obstructive sleep apnea. After that comes the obstructive hypoventilation or the obstructive hypopnea syndrome, in which you are having hypopneas and there is desaturation around 4% with an increase in PCO2, but it doesn't meet the apnea criteria. So that is called as obstructive hypopnea syndrome. And finally, this is the obstructive apnea florid syndrome, in which you are having significant apneas as well as hypopneas. So it's a spectrum disorder, and the patient may migrate from one part of the spectrum to the other part, depending on the obesity and the other factors and the treatment given. Now, what are the risk factors? As I already mentioned, advanced age, male sex, obesity, as we all know, and then there are certain structural problems in the craniofacial and the soft tissue abnormalities which can predispose to sleep apnea. Family history may be significant, smoking, nasal symptoms, menopause, postmenopausal symptoms, diabetes, hypertension, hypothyroidism, acromegaly. This all have a lot of soft tissue around the neck and the pharyngeal area, so this can predispose to sleep apnea. Pregnancy again causes the increase in the fluid accumulation and increase in the fat levels around the palatal, tongue, and the posterior pharyngeal wall muscles, causing giving rise to sleep apnea. And medications and substance abuse. So very important, benzodiazepines, alcohol, and all this can precipitate the symptoms of obstructive sleep apnea. So general factor, as the age increases, there is loss in the tissue elasticity and all those things are there, which gives rise to sleep apnea. Male gender, again, because of more of androgen. And obesity, as we know, there is more deposition of fat in the soft palate and the tongue and the other areas, which gives rise to sleep apnea. And alcohol and sedative drugs causes relaxation of the muscles, the genioglossus and the tensor veli palatini, which can precipitate sleep apnea. These are the anatomical issues which may give rise the changes in the craniofacial structure and soft tissue anomalies, micrograthia, retinograthia, large tongue, that is macroglossia, enlarged soft palate, the mandibular slope, and adenotonsillar hypertrophy, and all those things. So variety of symptoms, lot of syndromes, the facial dysmorphic syndromes, all this can give rise to sleep apnea, predisposition of sleep apnea, even in non-obese symptoms. So the importance is that it's not just obesity. Even lean individuals can have obstructive sleep apnea, especially in children. If they are having adenotonsillar hypertrophy or with craniofacial abnormalities, they can be more prone for sleep apnea. One important factor is neck circumference. So this is one of the most important measurements which causes obstructive sleep apnea, if it is more than 17 in men and 16 in female. So these are the anatomical factors which I have explained already. You can see, so long soft palate, then increased tongue fat and inferior hyoid position, lateral pharyngeal fatty tissue increase, and reduction in the length of the mandible. So this may be the common abnormalities which give rise to obstructive sleep apnea. So this is again a repetition. So there is a scoring called as the Malampati score, so which scores from 1 to 4. So this shows the chances of developing sleep apnea and the difficulty in intubation also. So you can see this is grade 1, in which you can clearly see the soft palate. Grade 2, you can just you cannot see the tip of the uvula, and then grade 3 you are able to see the base of the uvula, and the grade 4 you are not able to see the soft palate. So more severe is this. You can simply ask the patient to open the mouth and protrude the tongue and can have a look at the posterior pharyngeal wall, and then you can have a rough estimate what it is. So more severe the grade, more higher the grade, the more chances of obstructive sleep apnea the patient is having. Then the tongue size, whether the tonsils are hypertrophied, what is the length of the uvula, whether the palate is high-arched or narrow-arched. So all those things can be a predisposing cause, you can look into the nose whether there is any turbinate hypertrophy, any polyps which you are seeing, any DNS which the patient is having. So this is the obstructive sleep apnea cycle which the patient goes through whole night. So patient falls asleep, the upper airway relaxes, there is snoring, the airway in the throat closes and partially obstructs, the breathing stops and there is apnea, oxygen level falls, carbon dioxide level increases, the brain gets stimulated and it tries to increase the breathing, and then the patient awakens during the hypercarbia and the hypoxia stage. And again, this cycles goes again and again. There is hypoxia, hypercarbia, awakening, and then this cycle goes on and on. So what are the common symptoms which obstructive sleep apnea patients present to us? So the symptoms can be nighttime symptoms and the daytime symptoms. So nighttime symptoms, the history has to be taken from the bed partner or whoever observes the patient when the patient is asleep, because most of the symptoms may not be clear to the patient. So you have to ask the bed partner. So one is snoring. So if there is loud persistent snoring which is heard clearly, so that is one symptom. Second is witnessed pause. Sometimes you can see the patient relative says that suddenly the patient chokes and there is breathing gets stopped. So that is pausing, and there may be choking. Suddenly the patient may wake up with some choking sensation or gasping feeling. And then restless sleep, that may be one more symptom. They may be turning here and there in the night. So that is one symptom. And then nocturia. So nocturia may be again a predominant symptom of obstructive sleep apnea. Daytime, by the time they wake up, first symptom will be headache. So they'll be having a hollow cranial headache, which is present for maybe for half an hour to 1 hour, and then it goes off. So they'll be very tired, fatigued. They will be feeling that they are not slept properly. So non-refreshing sleep may be one symptom. Then poor concentration. So they are not able to focus properly. They doze off during work or whenever they are sitting. They will be irritable. There may be other symptoms also, memory loss and all those things. And especially while driving, it can give rise to sudden lapse in the concentration, or sudden naps may occur, so which may cause road traffic accident. So it may be a life-threatening situation. And in the Western countries, patients who are having severe obstructive sleep apnea, they are made to avoid driving, and there are rules regarding driving as well. So it is as important as seizure, epilepsy or syncope and all those things, having obstructive sleep apnea. So the other symptoms are hypertension, they may be there, arrhythmias and all those things may worsen. They may be restless, anxiety, mood disorder, depression may occur. They may be having memory loss, cognitive issues. Dry mouth is one symptom because they have mouth breathing. So they will be having dry mouth, and they may be having some nocturnal cough, nocturnal sweating, and symptoms like gastroesophageal reflux. So these all may be the symptoms. Now, what are the differences of obstructive sleep apnea in children? Now, children, the characteristics may vary. So first is it may be less prevalent. So it may occur in almost 1 to 2%. There is excessive daytime somnolence may not be there. So they may be more hyperactive. They may be having learning problems, impairment of growth and all those things may be there. The most important cause in children is adenotonsillar hypertrophy and some syndromes and obesity also. So usually surgery will give good result if there is adenotonsillar hypertrophy in children. And in the sleep study, the threshold for apnea hypopnea is less than 1. Unlike adult where it is 5, here the apnea hypopnea index threshold is lower. So the symptomatology of children may be different. So this is the summary of the things which we have to think of: the symptoms, the night symptoms, the morning symptoms, with a very high body mass index of more than 30, crowded oropharynx, that is the Mallampati score of grade 3 or 4, and increased neck circumference, 17 in men and 15 in female. So if these are there, we should have a very high clinical suspicion of sleep apnea. Now, headache during sleep. So it's not just sleep apnea. In neurology, a lot of conditions can cause headache at the onset when the patient wakes up, or which awakens the patient from sleep. So cluster headache, hypnic headache, paroxysmal hemicrania, and sleep apnea headache. So these are the 4 conditions which can awaken the patient from sleep. But the characteristic of headache will be different. Cluster will be unilateral, severe pain, periorbital pain. Hypnic headache will be more around 3 to 4 a.m. and it will be occurring every day at the same time, last for 1 to 2 hours and will subside. Paroxysmal hemicrania will be again unilateral headache with redness of the eyes and all those symptoms. So with the symptomatology, you can differentiate what type of headache it is. Now, one important thing is that the definition of obesity may be different in Asian population. So you have to see that in the Asian population, more than 22.5 BMI is considered to as obesity, while in the Western BMI criteria it is 25. So even lower BMI may be related to obstructive sleep apnea. So you have to be careful by taking the BMI. So it's not more than 30, it can be more than 22.5 is considered obesity. Now, one more important feature which I would like to project here is that the symptoms may not correspond with the severity of the obstructive sleep apnea. Suppose we are having a Epworth, this is a scoring scale for sleepiness. So Epworth scoring scale less than 9, dozing episodes, no hypersomnia, normal vigilance. So this is not a very severe sleep apnea symptom. So, but it may be having major end organ impact. And here you can see it is a very severe sleep apnea, but there is minor end organ impact. So there is no direct correlation between the sleep apnea severity and the symptoms. So you may be having a patient with very clinically significant sleep apnea like excessive daytime somnolence, severe snoring, apneas and all, but there may not be much of hypertension, cardiac involvement and all those things. And some patients may have very mild sleep apnea with severe symptoms. So there is no parallel correlation. So the clinical suspicion should be high, and you should investigate every patient wherever you suspect there is sleep apnea, because even the sleep apnea is mild, the symptoms wise, but there may be severe manifestations of the disease which you can pick up only after investigating the patient. So what are the multi-system effects of sleep apnea? So it's a generalized disorder. It's not a unisystem disorder. It's like hypertension, it's like diabetes, which affects the whole of the body. So in the brain, it causes cognitive impairment, memory lapses, excessive yawning, and sometimes hyperactivity, as I already told in children. It causes immune dysregulation. So it affects the lymph nodes and the immune function of the body, and causes a immunosuppressed state as well. It affects the pancreas and increases the risk of diabetes mellitus. In the heart, it causes arrhythmias, LVH, and all those things, muscle pain, muscle ache, and decreased sensitivity of the muscles, growth suppression, and all those things. Risk of obesity is also increased with sleep apnea. So obesity increases risk of sleep apnea, and sleep apnea also worsens the obesity. So it's a vicious cycle. Now coming to how it causes refractory hypertension. So it is a very important manifestation whenever you are having a patient who requires more than 2 drugs of antihypertensive properly chosen and given in the proper dose, and yet the BP is not controlled. Then you should suspect a underlying renal disorder or some obstructive sleep apnea which is causing the less response to the antihypertensive medication. So what is the mechanism? The intermittent hypoxias causes increased sympathetic stimulation, increased renin, increased angiotensin, and increased aldosterone, which causes abnormal vasoconstriction. It also causes reduction in the nitric oxide levels, which causes increased vasoconstrictive substances like endothelin 1 and all those things, and causes abnormal vasoconstriction, which increases the blood pressure. So it has a direct impact on the blood pressure. Now, one more important mechanisms which affect the cardiac function is obstructive sleep apnea, as I already told, hypoxia, hypercarbia, which reduces the myocardial oxygen delivery. It causes oxidative stress, inflammation, endothelial dysfunction. It causes reduced intrathoracic pressure and also increased sympathetic and reduced parasympathetic activity. So all this gives rise to increased blood pressure, increased heart rate, increased LV wall tension, cardiac oxygen demand, all increases, giving rise to all of this cardiovascular manifestation, that is hypertension, accelerated atherosclerosis, myocardial ischemia, LV hypertrophy, arrhythmias, and cerebrovascular accident. So all these are directly related to obstructive sleep apnea. So it is like diabetes mellitus, which causes a significant cerebrovascular risk. So obstructive sleep apnea is again an evolving important risk factor for cardio and cerebrovascular disorders. Now there is some immune basis to sleep apnea. So what happens is, whenever there is intermittent hypoxia, there is increased reactive oxygen species, and that causes increased transcription factor TIF alpha levels will increase, cytokines IL-6, IL-8, TNF alpha, IL-10 all increases. There is activation of the monocyte, lymphocytes, platelet as well as the endothelial cells. So overall all this causes a endotheliopathy, that is diffuse endothelial dysfunction, which causes cardiovascular morbidity and cerebrovascular morbidity. So it is similar to that in diabetes or CKD, where there is diffuse endothelial dysfunction. So this disorder also gives rise to diffuse endothelial dysfunction, causing to risk of all sort of vascular complications. Now, if you look at the prevalence of sleep apnea, there is increased almost 80% in drug-resistant hypertension, obesity 70-75%, CCF same 70-75%, pacemaker, AF, diabetes. So everywhere you can see that obstructive sleep apnea is a common predisposing factor. Now there are studies which shows that there is, if you look at the apnea hypopnea index, more than 15, it has an odds ratio of almost 3, and 5 to 15, 2.03. So definitely there is more than 2 times increase in hypertension, diurnal hypertension. Arrhythmia also, there is an odd ratio of around 3.4 for non-sustained VT, and complex ventricular ectopics 1.74, and AF there is 4. So significant risk of atrial fibrillation is also there. Similarly, metabolic dysregulation is seen, like reduced glucose tolerance, reduced insulin release, increased leptin, increased ghrelin, increased hunger and appetite, and increased risk of insulin resistance, glucose intolerance. So all these metabolic dysregulations make the patient more prone for diabetes mellitus, as well as worsen the diabetic control. So these are the studies. There are a lot of studies which shows that there is a positive relationship with diabetes mellitus. So you can see almost 60 to 80% there is a correlation with overall obstructive sleep apnea. Studies from all over the world, USA, UK, and all other countries, China. So they are involved, and it has shown a positive correlation with diabetes mellitus. Now coming to this may be of quite importance for the cardiologist. Major adverse cardiovascular events, MACE. So you can see that AHI more than 10 in male, there is 28% chances of adverse cardiac event, and for in female it is 20%. So there is a significant association with 5-year adverse cardiovascular events. And one important point here, restenosis after PCI, you can see that the chances is 37%, and which is statistically significant. So even after patients who are treated with stenting and all, there may be a higher chance of restenosis, and obstructive sleep apnea may be a very important risk factor in that. And sudden cardiac death around midnight to 6 a.m. There is high risk of sudden cardiac death in patients with obstructive sleep apnea, and the p-value is also significant here. So sleep apnea is a very important cardiovascular risk factor, like obesity, like obstructive sleep apnea, like diabetes and smoking. So you can see the gradient here, obesity, diabetes and smoking. So it's climbing up, and it's a very significant risk factor. So this routine history has to be included in the history of any patient presenting with diabetes, hypertension, stroke, or myocardial infarction. So the history of obstructive sleep apnea should be a routine in all history taking formats. Now, heart disease, when should you do a sleep study? So if there is, first is the symptom. So if you are getting the symptom, definitely you can do. But even without the symptoms, you should do the sleep study if there is nocturnal angina, if there is recurrent arrhythmia which is not responding to treatment, refractory heart failure symptoms, and if there is witnessed respiratory pattern or apnea. So definitely you can go for a quicker and faster sleep study in such patients. Even if the clinical indication, even if the patient is not very obese, you can definitely go for sleep study in these patients. So this is to summarize the overall metabolic problems. So intermittent hypoxia, sleep fragmentation, and then you get the sympathetic nervous system involvement, cardiac preload and afterload involvement, the hypothalamic pituitary axis is involved, there is oxidative stress, and all this leads to the problems with elevated blood pressure, metabolic dysregulation, systemic inflammation, endotheliopathy, and myocardial dysfunction, giving rise to the varied cardiovascular manifestations. So everything that occurs in sleep is not sleep apnea, is not apnea. So there are other things also which you have to rule out. One is primary snoring, as I already said. Patient may snore, but there is no actual apnea. So it's a sort of benign snoring. And you have to do a sleep study and document that the AHI is less than 5. Underlying pulmonary disorders. So you may be having sudden awakening in the night. So it's called as paroxysmal nocturnal dyspnea, which can occur in mitral stenosis patients. It could be some bronchial asthma, which may be worsening in the night, some mucus impaction, panic attacks, nocturnal asthma, gastroesophageal reflux disease can again mimic an apnea, nocturnal seizures, and insomnia. So all these are the differential diagnoses of nocturnal events, which we have to keep into mind. Then excessive daytime sleepiness, which is a very common symptom of sleep apnea. It can occur with many other sleep disorder. So you have to take a proper sleep history whenever this patient comes, or refer to a sleep specialist, so that other causes which may cause excessive daytime sleepiness has to be evaluated. For example, most common is sleep deprivation, then sleep apnea, obstructive or central sleep apnea, other central disorders, circadian rhythm disorders, RLS, restless leg syndrome, and periodic leg syndromes, which can present with these symptoms. So there are a host of disorders which can present with excessive daytime sleepiness, renal failure, hepatic failure, hyperammonemia. Many medications can cause this. So a proper history is important. Otherwise, we'll unnecessarily investigate the patient with sleep study. So first thing is the proper history and then examination. Then only you should proceed with the sleep study. So when the patient with similar symptoms comes to your OPD, how should you briefly evaluate this patient? First is a detailed sleep history has to be taken. So sleep history means everything. So when does the patient go to sleep? What food does he or she takes? What time the patient gets the sleep? So initial period, whether there is difficulty in sleep, the sleep onset, whether there is sleep breakage, how is the sleep, whether there is any snoring, whether there is any apneic episodes, whether there is any nocturia, what time the patient awakens. So everything has to be taken in the history. You have to ask about the daytime history, tiredness, fatigue, and all those symptoms which I have already mentioned, and then do a careful and brief targeted examination. So body mass index, most important, neck circumference you have to take, and do the cardiopulmonary examination. Blood pressure you have to take, just auscultate the heart for looking for any S4 which is there, which shows any uncontrolled hypertension. Look for the JVP, look for the lung basis, and pedal edema. So this briefly you can see. Take the drug history as well, what all medication the patient is on. Examine the upper airway for the palate and the scoring which I have showed. So you can look for that. Examine for any retinographias, look for the tongue, how the jaw is, what about the neck, all those things has to be examined. And then dental malocclusion is one important thing. So that also you can just see briefly. So there are few questionnaires which can be kept in the OPD before the patient reaches you, or it can be filled by your juniors. So this can be kept. So these are the questionnaires. One is the Berlin questionnaire, the Stop Bank questionnaire, and the Epworth sleepiness scale. So you can use Stop Bank or Epworth. So Stop Bank has the highest sensitivity, 88%, and but specificity is poor. And Epworth has 47% sensitivity and 62% specificity. So this is the Stop Bank questionnaire which can be used. It is quite useful and very easy. So snoring, S stands for snoring, T for tiredness in the daytime, O stands for any observed apneas, P stands for blood pressure, B stands for BMI, A stands for age, more than 50, N stands for neck circumference, which I already mentioned, more than 40 centimeter you can take commonly, and G stands for the gender, male or female. So these are just basic things. You have to check the blood pressure, age, neck circumference, body mass index, and few questions. So with that, you can have the Stop Bank questionnaire done. So that will screen the patient. So which patient you have to be careful, and which patient may have obstructive sleep apnea, you can definitely find with this questionnaire. So this is the sleepiness scale, Epworth sleepiness scale. Again, there are 8 situations, and then the patient has to mark how does the patient feel in this situation. And then there you can score it from 0 to 3. And if the score is more than 12, it is abnormal. So this can again be kept in the clinic, and this can be filled before you actually see the patient. So this will give an indication which patient is. You have to give extra time to examine and then evaluate the patient. So Stanford sleepiness scale is also there, which we do not use much commonly. And so this is the grade Mallampati classification, which I already mentioned. Then there is a Friedman tongue position score, so which shows the position of the tongue relative to the palate. So this can be used. And tonsillar size. So in children, this you can see grade tonsil enlargement can be graded as 0 to 4 plus when it touches the midline, and dental malocclusion. So all these things can be examined. So after examining, when should you investigate the patient, or when should you do a polysomnography? So if there is excessive daytime sleepiness on most days and the presence of at least 2 of the following features, that is loud snoring, witnessed apneas or choking during sleep, and diagnosed systemic hypertension, you can do a sleep apnea study, that is the polysomnography, either a type 1 polysomnography or a type 3 or type 4 home polysomnography. So polysomnography, I think Dr. Saurabh will explain about it. So it's a test which is done to find the sleep characteristics of the patient with lot of electrodes being put. There are 2 types, there are actually 4 types of polysomnography, type 1 to type 4, which he'll be explaining later on. Now, 2 important characteristics in polysomnography is, one is apnea. So if there is a drop in the airflow in the thermistor from more than 90%, lasting for 10 seconds, and if 90% of the event meets the amplitude criteria, you call it as apnea. Hypopnea is a milder variant in which the nasal pressure signal drops by more than 30% with a desaturation of 4% and lasting for 10 seconds. So these are the 2 important things, apnea and hypopnea, and based on that only we give the apnea hypopnea index, which classifies obstructive sleep apnea into the 3 varieties. And there are 2 types of monitoring. One I told is portable, in which the patient is at home and then there is a portable device which is fit, and then we do the study. And the type 1 is the proper study, in which we have all the channels, including the EEG channels, electrooculogram channels, and then there is the EMG channels as well. So the thing is that if you are having a suspicion of obstructive sleep apnea, moderate to severe, and you are pretty sure it is obstructive sleep apnea, then a portable study is sufficient. But if you think the patient is having excessive daytime somnolence, and it could be something else also, like RLS, PLMS, or some other sleep disorder, then it is better to do a proper sleep study, including all the EEG channels and everything as well. And also in critical care, critical workers, that means airplane pilots, bus drivers, taxi drivers, and all those things, train operators, police, security, military personnel, astronauts. So in this group, you should do a in laboratory polysomnography rather than the screening polysomnography. So these are the basic differences of home sleep apnea testing and inpatient in laboratory polysomnography. The most important is EEG data is not there, EMG data is not there, a technologist is not there in a home sleep apnea testing device. So the number of channels are less, the information which we get is less, we do not know which stage of sleep the patient is, and all those things so are there. But it may be quite helpful in patients who cannot be moved into the laboratory, who are not well, and in this COVID scenario also this may be helpful, the home sleep apnea testing. So this is polysomnography. I'll not go into the detail. You are having the channels, that is the EEG, EMG, electrooculogram channels, ECG is there. You are having the airflow channels and EMG channels for the leg movements. And then there are 2 belts in the chest and the abdomen for the movement of the chest and the thorax, and a snoring sensor as well. So all this will give the stages of the sleep which the patient is in, whether the patient is in REM sleep, whether the patient is in NREM sleep, what is the heart rate, what is the flow, whether there is any apnea. At the time of apnea, what was the abdominal and the thoracic movement like, and what was the oxygen saturation. So all this data we'll get from the polysomnography. So this is the home study in which you are having limited number of channels. You are having the snoring detector and the abdominal and the thoracic belt, as well as the oxygen saturation. So these are the 4 parameters which we have in the type 4 sleep study. So based on this study, the patient can be divided as mild sleep apnea when the AHI is 5 to 15, moderate 15 to 30, and severe when it is more than 30. And then you have to decide on the treatment. And so the diagnosis, you can see it's basically on this criteria. I think Dr. Saurabh will be speaking about that. Now, the treatment of obstructive sleep apnea, first is conservative, that is weight loss and all those things, limit alcohol, benzodiazepines and opiates. And then the most important thing is the positive airway pressure, CPAP, BiPAP or AutoPAP, whatever machines you are using, you can use. And then second treatment is oral appliance therapy. And finally, the surgical treatment, which Dr. Uttam Agarwal will explain. So I'll not go through this. Apart from the polysomnography, there are few other tests which is required if the surgery is planned. So X-ray cephalometry, CT scan of the neck, dynamic MRI, and a very important test, that is drug-induced nasal endoscopy to assess the upper airway, which will again be discussed by Dr. Uttam Agarwal. So to summarize, obstructive sleep apnea is a very common disorder and presents with varied manifestations and atypical manifestations as well. And it can be easily missed, where very high index of, high clinical index of suspicion has to be there to diagnose this condition. It can have significant impact on the blood pressure, heart diseases, diabetes, and the functioning of the brain. And high risk group should be evaluated meticulously to rule out obstructive sleep apnea. Proper sleep history, questionnaires, body mass index, neck circumference, and oral and pharyngeal examination is required. Polysomnography is the gold standard for evaluation, diagnosis, and a multidisciplinary team approach, including the neurologist, the sleep specialist, the ENT specialist, the dental doctors, and whole lot of teamwork is required for proper management of these patients. So thank you for your patient listening. Thank you.
So it was wonderful, Dr. Yadav. It was very exhaustively covered right from the beginning of symptoms to the end of how we should approach the patient, the history taking, and the examination part. I think we should move on to Dr. Saurabh Das, who will speak on polysomnography and the medical management.
Hello, am I audible?
Yes.
Yeah,
Saurabh.
Yeah. So, okay, fine. So actually, a lot of things that were in my slide were already covered by Dr. Praveen. So what I'll do is that I'll be skipping those slides, or speaking very briefly on them, and let's see how much we can cover today. Okay. So just give me a moment, please. Yeah. Yeah. So are the slides visible?
Yes, it is visible.
Okay.
yeah.
Okay. So today I'll be speaking on the diagnosis and medical management of obstructive sleep apnea, including the polysomnography and scoring system. Now, since the time allotted to me has been only 15 to 20 minutes, I don't think that detailed scoring will be feasible in such a short time period, because we usually take workshops on how to score a polysomnography, a 2-day or 1-day workshop. So what I'll be doing is that I'll be showing some slides and discuss a little bit about how the scoring looks like. Okay, so just kind of revision of the basics, as Dr. Praveen has said very nicely. Obstructive sleep apnea is a potentially serious sleep disorder in which breathing repeatedly stops and starts during sleep. Now, when we try to look at a potential obstructive sleep apnea or OSA patient in our clinic, what do we have to look for? Most of the patients are typically male in the age range of 30 to 60 years, had history of snoring, daytime sleepiness. Sometimes they do complain of choking or gasping at night. And it is very, though it is like, we commonly read that there are witnessed apnea during sleep, but this is actually very rare in the Indian scenario. Most of them have moderate obesity, but large neck circumference, and some may present with mild to moderate hypertension. Now, I would like to add a few things here, is that though the common presentations are between 30 to 60, in the Indian scenario, what I have commonly seen in my practice, it's that like most of the people, like those who are in the 30 to 40s age range, they present with the most severe form of the disease. Like they will have an AHI which will be very close to 100, they will have a huge amount of desaturation and all those stuff, and they are in their 30s, like late 30s, early 40s, like that. On the other hand, when we see patients who are nearly 60 years or above 60 years, they usually present with moderate to just on the cutoff. They're just crossing the cutoff of severity range, and that kind of apnea they present with. So what I'm trying to portray here is that though the typical scenario of OSA is something that we grossly look for, like 30 to 60 years and this and that, but there are actually phenotypical differences in a great extent among various individuals. So we just have to keep our eyes and ears open and see what we are getting. On the other hand, women with OSA are mostly postmenopausal, that is in the late 50s or late 50s. Snoring is usually less frequent. Daytime fatigue and headache are actually more common than outright sleepiness. So this is just a pictorial depiction of how an OSA patient looks like. Now the question is that who will have OSA and who will not. The common consensus will be that the guy on the right, extreme right has the most chance of having OSA, but this is actually not true. All of them have a reasonably good chances of developing OSA, and on the other hand, this particular guy can actually have no OSA. That is possible. That is very much possible. So we have to keep in mind that though obesity increases the chances of OSA, but that obesity is not the only risk factor. The symptoms and OSA clinical examinations have already beautifully been covered by Dr. Praveen, but I would just like to rewind very briefly once again that when we get a patient of OSA, like say for example, I'm um, looking at a patient from my specialty, and my specialty can be anything XYZ. Now, if I get a patient who is complaining of certain daytime and nighttime symptoms, I'll be like I should be alert that whether there is some hidden OS in the patient. Now, among those daytime symptoms, of course, the symptoms have been described. Now, one particular thing I'd like to focus is that at lot of times, anxiety, low mood changes, and gastroesophageal refluxes are actually pretty common in OSA patients, and they do present to doctors of different specialties with these complaints. Now, on particularly now after probing those patients further only, we will get the history of these apneas, witnessed apneas or snorings and all those stuff. So like what I'm trying to convey here is that a patient may come to you with the complaint of that I'm having irritability or depression, or I'm having, doctor, I'm having a lot of gas and reflux. So we of course should be checking them for all the disorders according to our specialties, but at the same time we have to take like we have to remember in our mind that these can also be a symptom of obesity of OSA. Now, if we think that this person may be having some OSA, we'll be going for a clinical examination. But now in a very busy OPD, it is usually not possible to have a full-fledged clinical examination for all the suspected cases of OSA. That is, of course, understandable in the Indian scenario and context. So what we can basically do is that we can just have a look at the patient's neck, or just like the neck circumference. Rough idea is often good enough to understand whether the person's neck circumference goes above the cutoff or not. The BMI can be very easily calculated. There are lots of mobile apps nowadays which scores the BMI of the patient, and we have to just ask the patient to open his or her mouth, and by looking at the mouth we can see the like Malampatti score, and we don't need to score the entire thing. We just need to see whether the uvula and the posterior pharyngeal wall is visible or not. If that is not visible, then that the person is having a good risk of OSA. So, and the others are of course there. So I'll be skipping these slides because they have already been described by Dr. Praveen. And there is something Friedman's classification, which I'm sure Dr. Uttam Agarwal will describe in detail, because that is more important and relevant from the surgical perspective. And Epworth sleepiness scale is a generalized scale which measures how much sleepy you are in the daytime, and this actually increases in all kinds of sleep disorders, not only OSA. So it's a very generalized scale, but it does help to rule patients out, who may be having some underlying sleep disorders, including OSA. Stop bank questionnaire has been described. Berlin's questionnaire has already been described. Now, I would like to add that a Hindi translation of Berlin's questionnaire has been formulated in our country, and I had been fortunate enough to be in that particular group which made this. And we did use at one point of time this questionnaire very effectively, and it had been used in many research theses as well. Now coming to the polysomnography types. So basically, to summarize briefly, what we have understood till now is that uh, in our routine practice, we are seeing patients of different specialities to us, because you know this webinar, as I understand, is attended by people from various specialties and disciplines. So whatever specialty we are in, when we see a patient, we can be alert that okay, this person may be having some underlying OSA. We do a very rapid physical examination. We try to get a little bit of history from the patient. Now we have to ask the patient to go for a polysomnography sleep study. Now, this is a very important part, because polysomnography is an umbrella term. It means that studying the person's sleep. Now, it can be studied in various degrees of depth. So starting from level 4 to level 1, as we go higher, like from level 4 is the lowest level and level 1 is the highest level. Now these levels are made like classified based upon how many parameters we are observing while the person is sleeping. So I'll come into that in a bit later, but let's just get familiar with the devices or the device which does these testings actually. So if we look here at the image A, this is basically a level 4 device. It measures only the airflow. We can see the nasal cannula here. It measures the airflow of the patient. Sometimes it can also have associated like oximeter, which will measure the patient's desaturation. In other cases, there are some devices which measure only the oxygen saturation or desaturation of that patient in the internet, and there is no airflow. So basically, this is a level 4 device which measures only one or at most two parameters of that patient. Now, these B1 and B2 are level 3 devices of various companies. They measure, in addition to these airflow or oximeter. We can see here the oximeter is there, here this oximeter is there. So these machines are capable of measuring the airflow, the oxygen desaturation, along with that the pulse rate, and we can see that there is this chest or abdominal belt which has been put. It also measures the respiratory effort. You know? Now, the newer models can also have some position sensor, that is, which will say that whether the person is sleeping on their right or on their in a supine position or on their left, and that can be uh, obtained. This data can be obtained using these devices, the latest models. But the general models, they at least have this airflow, this oxygen saturation, desaturation, this pulse rate, and this abdominal or thoracic effort. That is the effort well. That is how much effort is being put into the respiration. Now, this is the level 1 device. Now, actually, this device can be used both for level 1 and level 2. This has, we can see that in this image here, that this person is having a lot of watts at the machine. This is the size of the machine. You just compare it with the previous device sizes, this and this or this, and you compare it with this. This is the device, and this is the box through which like all the leads are connected. So we can see that there are leads which are connected to the head of the patient. There is lead which connects into the nose of the patient, in the chin, in the temple, in the chest. There is one in the abdomen. We can see again the oxygen saturation. Actually, this picture does not show all the leads attached, because you can see a lot of empty spaces here. So when we fill all those spaces, it'll look more like a sci-fi movie with a lot of wires and leads being attached to the person's head. There are leads for the masticatory muscles of the patient. There are leads for the limb movements attached to either the legs or the arms or both sometimes. And also we can have as an option the facility to record the entire thing through infrared videography, which will help us find out a lot of about movements and all stuff. So this is a level 1 device, and this is called a level 1 study, where we monitor a lot of different parameters which I had just mentioned. Now, not only by measuring these parameters can we call this study a level 1 study, this will be called a level 2 study, unless this entire monitoring is done live by a technician or attendant throughout the night. Like what happens, or like what is the difference is that this is the patient, this is the patient, and this patient has come to the lab and has all those wires fixed and everything, and he has gone to sleep. Now, while the person is sleeping, there has to be a trained sleep technician who will be sitting in an adjoining room and will be monitoring all these data being transmitted to that computer system, which will show all. I'll come to that part a bit later as to what will be shown in the screen. So he'll be monitoring the screen and seeing if there are any leads which have come out, or if any lead has become loose, and whether the data quality is all right, and a lot of other stuff the person monitors. And if the person monitors it for the entire night, then the patient wakes up in the morning and leaves for home, and that is the data which is processed and done as a level 1 study. So this level 1 study means the person has to monitor it completely throughout the night, because these leads are very prone to getting loose or giving in bad data or some artifact. So that has to be corrected live while the study is being done. Now, if you do all this setup without uh, putting the technician in, then what you get is called a level 2 study. And this is a particular device which is very popular in our country. It has the best features of both level 1 and level 3 basically. It has a capacity to do almost all a lot of these level 1 leads, but it compromises on the EEG channels. It comprises EEG channels, but it is a very portable thing. You can see the size of this device, and it is much less expensive than these models also. The problem is that American Association of Sleep Medicine categorically mentions that to be called a level 1 study, there has to be at least 6 or more EEG channels. Now, this machine is capable of putting at least, I think, 1 or 2 EEG channels. So it is not always feasible that you will put 6 EEG channels in this. So that is one of the major drawbacks. So it basically, technically, it falls somewhere between level 1 and level 3, not exactly level 2, because you can always monitor it live while the study is being done. So these are the basic machines that are available in our country and in most part of the globe regarding the polysomnography. This had already mentioned that this type 4 study mentions a few of the cardiorespiratory parameters. Type 3 study mentions some more cardiorespiratory parameters, and type 1 and type 2 studies measure almost all the parameters. Now we'll come to the benefits of in-lab versus portable sleep testing. So basically there are benefits to each of these type of studies. Let's come to the portable sleep testing first. The portable sleep testing, which is done at patient's home, they are much easier to conduct and interpret. They are helpful for those patients who are in like a critical care ICU setup, those who are immobile, and those who are infirm and very difficult to bring them out into the sleep lab. It can also be done in the ICU settings as mentioned. And most important part is that they are very less expensive and the patient can sleep in their familiar home environment. So these are the benefits of doing a portable sleep testing. For all practical purposes, the most important benefit of doing a portable sleep testing is the cost, because the cost of doing an in-lab PSG is a bit expensive on the higher side than the portable sleep testing. However, when we do a sleep test in lab, that is much more authentic and much more elaborate. A lot of channels, like to the range of 55 to 60 channels, are used for monitoring all the data sets of that patient. You just compare it to 4 or 5 or 6 channels in the portable sleep testing. And this level 1 study has the ability to diagnose the full spectrum of sleep disorders, not only the OSA, but along with the other comorbidities also. Most of them can be measured with in-lab PSG. And it can take a large data volume and it can be run for an unlimited period, whereas the portable thing runs on there. There are some limitations as to how much, for how many hours it can be run. Usually it's around 6 to 8 hours. Now, video recording can be added to the in-lab PSG, which is very helpful to sort out the dubious cases and certain things which are a bit doubtful, and particularly important for some different sleep disorders called parasomnias or nocturnal seizures, which are often coexistent with obstructive sleep apnea. So, and not only the type of study or the type of machine or device that is used, but another very important part is how the data is processed or how the PSG is scored, as we call it. Usually the recommendation is going for manual scoring, because when we do score the data manually, we divide the entire night's sleep into 30-second slot, and we try to uh, evaluate how each of those 30-second slots, like what are the data that we can obtain, or what are the points that we can see in that 30-second slot. With 30-second interval, we score for the entire of the sleep study. Now, this is for the particularly for the EEG set of channels. Now, for the cardiorespiratory parameters, we score the study in terms of 2 minutes of epochs. Epochs is what we call for each set. Now, this is recommended way, because not only you get to know the exact correct data, because till now there is no computer, no software which is able to classify the EEG or interpret the EEG tracings perfectly, like or better than a human being who is trained in scoring polysomnography. So, and if the EEG scoring gets disrupted, you do not get get the proper sleep staging, and so the stages are all wrong. Sometimes wakefulness is classified as sleep, sometimes sleep is classified as wakefulness, and therefore whatever data you get, including the HA and all the other stuff, they all go into the dustbin. So basically, manual scoring is the way to score a sleep study properly after doing a elaborate PH. So basically, before okay, and these are the recommendations by American Association of Sleep Medicine for portable monitoring. I will not go into the details, but just as a practical solution, what we do usually is that if we see that a patient who is at risk of obstructive sleep apnea, and if we are sure that the person is having a very high risk of obstructive sleep apnea, along with that, there are issues about the patient's affordability or issues about accessibility of that particular patient to a sleep lab, then a lot of the times portable sleep testing is better than no sleep testing. But on the other hand, if we can see that the patient is having a risk of OSA, but he can afford an in-lab PSG, it is always preferable to send the patient for an in-lab PhD to get a comprehensive evaluation and assessment of that patient's sleep problems, because a lot of the times we see that the patients do have a lot of comorbidities along with OSA, which are often missed by the portable sleep testing, and as a result, once the testing is done and treatment is started, the treatment is not comprehensive, and the patient keeps on moving from doctor to doctor in search of a cure. So those things can be removed if you go for a in-lab PhD directly. And one thing I must mention here, that regarding this cost thing, when this type of study started in the United States of America, I think 2 or 3 decades back, the difference was huge, like between the in-lab and the portable sleep testing. But in India, the cost difference between a portable sleep testing and in-lab PhD is very minimal, like hardly 2 to 4 thousand of rupees. Compare that to 2 to 4 thousand of dollars in USA, where the difference in cost between in-lab and portable sleep testing is there. So the difference in cost is not that much. However, there is actually a paucity of in-lab PhD and accessibility. Like you cannot send all the patients for in-lab PhD because there are not that much quantity of in-lab PhD centers in our country, particularly in West Bengal. Okay, so portable, just like take home message, portable monitoring oximetry is it to in-lab PhD is similar to what chest X-ray is to CT scan for lung cancer, and fasting glucose is to oral glucose tolerance test or oral glucose challenge test for diabetes. So this is how a sleep lab looks like. This is my sleep lab. We can see here that this box contains a machine. There is the head box. A lot of wires are there. The patient sleeps here. Some attendant can sleep here. The patient party can sleep here. Now this lab is that of Dr. Uttam Agarwal. You can see, the bed and everything. So it has a nice roomy feel rather than a typical hospital bed, so that the patient can sleep comfortably. And this is another level 1 sleep lab that is there in Calcutta. So, and these are the various level 1 sleep labs that are present internationally. Like they are from Australia, and this one is in the USA. So you can see that they do not look at like hospital beds at all. It looks completely like a bedroom. So these are similarly some Western sleep labs. How you can see how they are different from the hospital bed. So these had already been mentioned, I think, by Dr. Praveen. Obstructive sleep apnea, classification is that, as Dr. Praveen has mentioned, that this is a spectrum disorder. So it can start with intermittent snoring, which does not have that much of a health sequelae. Upper airway resistance syndrome. This is one category which I think I'll drop for because of time constraints. Mild OSA is when AHI is between 5 and 15. Moderate OSA is when AHI is between 16 to 30. And severe OSA is when AHI is greater than 30. So AHI means apnea hypopnea index. Like we count all the apneas and we count all the hypopneas that is present in the total sleep time. That is the total time for which the person is sleeping. And we divide the apneas and hypopneas by the total number of hours the person has slept, and what we get is called as the AHI. Okay, now these I think had already been discussed by Dr. Praveen. I'll skip these slides. And one thing I think I should mention here is that now this particular thing, apnea, has further been classified into 3 types. One is called obstructive apnea, another is called central apnea, and the other is called mixed apnea. So what the difference is like? The difference is like in obstructive apnea, the air is not getting inside the lungs, but the effort to breathe is there. That is, the chest or the abdomen is moving, but the air is not getting into the lungs because the upper airway tube has collapsed, either like almost fully, since this is apnea. Now, central apnea means that air is not going into the lungs. Why? Not because there is some upper airway collapse, but because there is no drive for having a breath or taking a respiration. So in central apnea, there is no chest or abdomen movement, and naturally there is no breathing effort and no air is getting into the lungs. In mixed apnea, it is something which starts as a central, like there is no breathing effort, there is nothing. After a while, the breathing effort starts, like the chest abdomen start moving, but air is not able to enter into the lungs because there is a upper airway collapse also. So these 3 types are called obstructive central mixed apnea. Now, respiratory disturbance index, or RDI, is another term which needs to be added here, because this is basically AHI, like apnea and hypopnea that we had discussed earlier. Now, if we add this RERA, or respiratory effort related arousal, to apnea hypopnea, what we get is called respiratory disturbance index. So respiratory effort related arousal is basically a flow limitation which is kind of prolonged along with some associated arousal. Like there is some obstruction, some degree of obstruction in the upper airway that leads to decrease in the quantity of airflow that is getting into the lung, and that leads to some arousal. But this does not satisfy the criteria of either hypopnea or apnea, because in most cases the oxygen saturation remains normal. So that is called an RERA. There is much more to this than the simple line that I mentioned, but I'll not elaborate on those lines today because of time paucity. So basically, RDI is a better index of what is happening in the person's sleep than AHI, and nowadays the classificatory systems are moving more towards RDI than AHI typically. So just to come into how, like, so we have by now we have understood that what obstructive sleep apnea is, what are the disturbances that are happening inside, and how that affects an individual, how it affects the person's health, and various consequences that are there. And also, how do we clinically evaluate a patient, and how do we use the rating scales, and how do we test the person for the specific things as to obtain the sleep quality, including the obstructions and all these, in by ordering a polysomnography, and what are the types of those. Now, in this part of the presentation, we would like to discuss how the polysomnography data looks like and how to interpret those. So I'll start with a schematic representation before going into the actual slides. So this is, we can see that this is just an airflow. This is an airflow, this is normal airflow, breathing, then expiration, then inspiration, breathing, like this is happening. Now, this is the airflow, that is the channel that we use, put on the patient's nose. And this respiratory movement is the channel that we put on the patient's thorax or abdomen. We can see that they are happening in tandem, and for every effort, there is this movement is there. So this is normal. And central apnea, as I had mentioned, that the airflow stops because the respiratory movement also stops. So there's a pause, and this pause has to be at least for two breathing cycles. Basically, there is a pause, and then again things resume. So this is a central apnea period. This has to be more than 10 seconds. In the mixed apnea, as I had mentioned, that this I think my battery is getting low. Okay. Okay, so let's continue for a while. So this airflow in this mixed apnea, we can see that there is this pause initially. Later on, there is this chest abdomen movement resumes, but the airflow is still not there. And in obstructive apnea, the chest abdomen effort is continuously there, but the airflow is not there at all because there's some obstruction in the upper airway. So this is how a slide looks like. Now this is a 30 seconds epoch. We can see this is this is the person who is sleeping here in his bed, and all the wires are attached to him. So this is how the EEG looks like. We can see the EEG is there. There are certain tracing which shows that there are some periods of arousals in there, and there are various data sets that we can get. For example, there are the leg EMGs are there, the chin EMGs are there, and there is this microphone for picking up snoring. There is this airflow to pick the person's there are two actually sensors which goes into the person's nose in level 1 pH. One is this flow, and one is called a thermistor. The other one is called the cannula. The thermistor measures only obstructive apneas, like whether airflow is present or absent, by noting the change in temperature between the air that is coming out and the environmental temperature. And the airflow, this measures both hypopneas as well as apneas, and this acts by measuring the speed or force of the airflow through the nostril. Now these are the abdominal and thoracic belts, like these belts you can see here and here. These are these belts, the graphs are there. This is the oxygen saturation, this is the pulse rate, and this is the plethysmography. So, and these are the EEG tracings we can see, EMG tracings we can see when the person's legs are moving. Basically, this person had some other disorder called PLMD, and we can see how it looks like here. So now for measuring these respiratory events, we have compressed this file into 2 minutes epochs, and we can see the EEG has got compressed. And this is how the breathing now looks like. We can see that this breathing here is, the degree is much lesser. Along with that, there is some arousal. Similarly, we can see the breathing is less here compared to this one, and we can see there is desaturation is there. And this part we can see that there is, as I was mentioning, there is no effort from the abdomen and thorax, and there is no airflow either. So this is a central apnea. And this, on the other hand, is what we call a central hypopnea, where we can see that there is no effort on the chest and abdomen, but there is some partial effort in the airflow. So that this is called central hypopnea, and we can see that oxygen level has fallen down from 98% to 94%, along with an arousal. The person there was some arousal, degree of arousal in this slide. So this is obstructive apnea, where we can see that this chest abdomen effort is there, but the airflow is completely stopped, and the desaturation is there from 98 to 86. We can see. Similarly, here it has gone from 98 to 89, and we can also see that this person is sleeping here. So like these, there are a few slides which I had put here just to see that how these movements look like, and this is how the EEG tracing looks like. So by this EEG can be used to figure out which stage of the sleep the person is in. Like there can be wake stages when we get this thing for the entire epoch. There it can be stage 1 or it can be stage 2. Stage 2 is when we have something called like sleep spindle and K complexes. This is a K complex. This is a K complex. This is a K complex, which denotes stage 2 sleep. And it can also have stage 3 sleep when it becomes like more like mountains. Like this looks a bit different. So I don't think we do have a stage 3 here. Okay, so now after we have done the PhD, we get a report like this. The sleep lab or sleep center, they do manage to give a report to you. How do we measure a sleep report? What we do is that okay, just give me a moment. I'll just pause the thing for some time, and I'll just add the charger to it. Just give me a moment. Yeah. Okay. So we were okay. So after we get this polysomnography report, how do we? What are the things that we need to look at? We need to look at like when the this is lights off and this is lights on. Like for how much duration the study had been conducted. The total recording time has been is usually mentioned, and total time in bed, and the sleep period time. The most important part is total sleep time. We have to see how much time is the total sleep time. Okay. So this is 125 minutes. This is not a full sleep study. This was actually a study in which first half of the night we did the study only, and the second half we managed to titrate the patient with CPAP. I'll come to that a bit later on. So basically, we look at the total sleep time, and by calculating the time spent in bed and the time total the time the person slept, we find out what is called as the sleep efficiency. So we can see that sleep efficiency of this particular patient is 63.7%. It is a poor sleep efficiency because the normal sleep efficiency is 85% or higher. So we have to know about how the person's sleep efficiency is, how much time the person took to fall asleep. In this case, it took around close to half an hour. Again, this is abnormal because usually it takes between 8 to 15 minutes of time. This is the wake after sleep onset, that once the patient sleep started, how much time the person spent as awakening. So this is again is high on the higher side. REM latency I will not discuss because I don't have that much time today. So then we come to the sleep staging, like how much percentage of the duration the person spent in which amount of sleep. For example, the N1 sleep was 11.2%, N2 44.8%, N3 32.8%, and REM sleep is 11.2%. So normally the N1 is less than 5%, N2 is a bit on the higher side, 50 to 70%, N3 and REM sleep both are in the range of 20 to 25%. But in this case, we can see that the N3 is higher and REM sleep is lower. But this is actually not very abnormal for this patient, because since we did this study only in the first half of the night, where the N3, the deep stage is normally higher. Like the more N3 comes in the first half of the night and more REM comes the second half of the night. So we should not take this report, this sleep staging division as abnormal completely. Now we'll have to come to about this respiratory part. We can see that this is a table which mentions a lot of things. We just need to see this thing index, that is events per hour of total sleep time. So this is here the central apnea. There were 1.9 central apneic events per hour of sleep time, 2.9 events of obstructive sleep apnea. There were no mixed apnea events. And so the total apnea events were the sum of all these three, which is 4.8. Hypopnea events were much higher at 24.0. So apnea and hypopnea becomes 28.8. So basically, this is the AHI. Apnea plus hypopnea event is 28.8 in this patient, and respiratory effort related arousal is 3.8. So we get an RDI on the even higher side, which is 32.6, which falls in the severe classification because that is more than 30. Now also we can, another thing that we need to look into this particular table is that this REM index, like whether there is higher apnea events in the REM sleep or compared to that in the non-REM sleep. But here we are not seeing anything which is very specific. Now then we also have to look at the arousals as to the arousal index, like how many arousals happened in 1 hour of sleep. So we can see here, which is 18.7, which is again on the higher side. Another thing that we need to look into in a level 1 study report is the limb movements, because they also contribute to the factor of non-refreshing sleep by the individual. We have to look at this called something called PLMS, which is periodically movement syndrome, a sequence which is on the higher side, like a tiny bit on the higher side, which is 19.2 events per hour. Normally it is 15 or less for adult individuals. So after looking at the time spent in bed, the total sleep efficiency, the time the person took to fall asleep, and how the sleep stages were there distributed, and whether apnea, hypopnea were there if present, which is how much, like mild, moderate, or severe. We look at whether there was any discrepancy in the REM part of the sleep, and how many arousals were there per hour, and how many leg movements were there per hour. So after that, we do look at the snoring episodes with the person snored approximately 64% of the time the person was asleep. We also look at relative desaturations, like how many total desaturations were there in the entire night. So we can see that there were 50 desaturations in those 2 hours of sleep that the person was sleeping. We also look at the minimum SpO2 level at each stage of the sleep and the overall SpO2 level in the entire study. So we can see that in this person, the minimum SpO2 fell to 81%, which is quite low. We also look at the cardiac summary. We look at the highest heart rate that was scored, we also the lowest heart rate that was scored, and what was the average heart rate during sleep. So these are more or less in the normal range of this for this patient. Last but not the least, we look at the sleep hypnogram, which gives us overall view and idea about this. In this one slide about the entire person, how the person is sleeping, we can see that this is the EEG part. This shows the different stages of the sleep, like wakefulness and N1, N2, N3 deep sleep, again the REM. And we can see that the deep sleep part is more in the beginning of the sleep. This is actually normal. Then the person was awake for quite some time, and then she went into and out of sleep periodically. And also we can see that there are this part denotes the oxygen concentration levels. You can see that the oxygen level was fluctuating, but mildly there was this part where the oxygen desaturation was on the higher side. Like we can see this has gone a bit down. Similarly, this was again on the higher side, and we can note that in these two periods when oxygen desaturation was on the higher side, we can see this red dot. These denote the REM sleep. So while the person was having the REM sleep, the oxygen level fell further below the normal levels, like further below how it was present for the rest of the night for this individual. The next part denotes the heart rate, then it denotes the arousals. Then we can also know about how many leg movements were there. We can see the person had frequent leg movements throughout the night. Then comes the central apnea, obstructive apnea, mixed apnea, and hypopnea. Then comes the respiratory effort related arousal. We can see that a lot of hypopneas in the study, like compared to apneas or hypopneas, compared to apneas or central apneas. And then it gives the idea of position. We can see the person did not turn much. She was supine position most of the time. And this part is for the titration part that I don't need to discuss today. So coming to this, so by this thing we come to the conclusion that the person is having a like severe obstructive sleep apnea with higher desaturations observed in the REM type. So and the person was spending most of the time while the person was on the supine mode. So how do we treat that? So the first we have to find out what the treatment objectives are for treating an OSA patient. Objectives are obvious. We have to reduce the mortality and the morbidity. Particularly, we have to reduce the sleepiness, like the daytime sleepiness, and we have to reduce the cardiovascular consequences. And last but not the least, we need to improve the quality of life of the patient. So when we take a therapeutic approach, like we first have to do some risk counseling. Like we have to we have to mention about the risk of motor vehicle accidents, job related hazards, impairment in judgment, to the patient, because suppose we start the treatment, it may take a few weeks to a few months to get the patient treated completely, and in the meantime patient drives the vehicle and dies, so the entire thing becomes pointless. So this is something which is like often missed, but it's a very significant thing, that you need to risk counsel the patient regarding the various hazards associated with OSA diagnosis. And we also have to treat the not only the apnea but also the comorbidity in terms of the behavioral part, the medical part, and the surgical part. Now, in terms of the behavioral interventions, we have to encourage the patients to lose weight. This is the first and foremost thing. Along with that, we have to ask the patient to avoid alcohol and sedatives to a great extent till the obstructive sleep apnea treatment is done considerably. The patient has to be avoided, has to be requested to avoid sleep deprivation, and the person can be requested to avoid sleeping on the supine position, and smoking also has to be avoided, because this smoking and alcohol, they even irritate the upper airway more, and they can cause more constrictions while the airflow is happening at night. So this I'll just skip. So we can see that this weight loss is a very important part for any obstructive apnea treatment. And I have seen a lot of patients who had been prescribed a CPAP, I had diagnosed as severe OSA, and treatment was given CPAP and all. And after 2 or 3 years down the line, the person managed to lose their weight so much that the entire thing became redundant, and the person had got rid of their OSA. So weight loss is a very important part, and there are actually studies done which shows that how much weight loss decreases how much sleep apnea. This is the graph there. If there is 10 to 20% of weight reduction, we can see that the mean change in AHI is more than -3. On the other hand, if there is 10 to 20% weight increase of a person, the AHI increases very significantly, right? This is another graph showing the same thing. So another is called sleep position training, which is a very simple thing. Basically, here we can see a pocket has been stitched at the back of the t-shirt this person is wearing, and a few tennis balls are put into it, so that whenever the person tries to sleep on a supine position, there is some discomfort, and the person again turns to either of the sides. So thereby we can decrease the something called as positional obstructive sleep apnea. In this particular patient, as we have seen that most of our apneas are happening in the supine position, we can actually give this method a bit small trial. So coming to the major part of the non-surgical treatment for OSA is this continuous positive airway pressure, which was first devised by Dr. Colin Sullivan in Australia in 1981. And since then it has been an entirely different journey altogether. So what he did is that this is the person's upper airway. We can see this is the nose, this is the mouth, this is the tongue, this is the pharynx, this is the palate and everything. So what he has done is he has put an airway and put a device which throws air into the pharynx, and it causes a pressure which pushes the this palate forwards, thereby creating a passage of opening of this airway like a pneumatic splint. And this is what basically CPAP does. It opens your upper airway. So initially it looked like a very big box, and this is what happens. And the earlier equipment which were used in the early 1980s, where they looked very clunky and very big. Some even had a nose-like shape attached to that. They are very earlier models, but gradually things have improved. Now much sleek and smaller devices are available. We can see that this airway is closed when the person is sleeping. Now we put this airway device and air flows through it, and there's this thing opens because there's a pneumatic splint in place. So how CPAP works, we can see that this airway, this is the upper airway. We can see that this is the upper airway of a OSA patient. Now as the pressure is increased by the device, these are all centimeters of water pressure, like 5 centimeter water, 10 centimeter water, 15 centimeter water. We can see that this airway passage is actually increasing. This is the person's upper airway. This is a basically axial section, and we can see how this airway is increasing with increasing the CPAP pressure. However, there are problems with acceptance and adherence in a quite significant amount of people. Now we can see that how in upper airway CPAP happens. This is kind of a sleep endoscopy which has been done, when you can see that this is a normal, this is how the upper airway is in a OSA patient. This is how this upper airway is once the patient who has been given a CPAP for quite some time. And this basically also acts by reducing the chronic vibration occlusion of the airway, thereby reducing this local edema of the upper airway. This CPAP works. So there are different types of PAP therapy. PAP therapy means positive airway pressure. One is called CPAP. like which gives a continuous pressure throughout the night. You just set the pressure on 10 or 11 or 12 centimeter of water and give it to the patient, and the patient wears it every night while going to sleep, and this continuous pressure is given. Now this is called APAP, or automatic positive airway pressure. What it does is that it varies the pressure level with each breath. Like with every cycle of respiration, the pressure is changing. This is a quite a convenient thing, particularly because the pressure that is required for an individual is not the same for the entire night. It changes on night to night. It changes upon how tired the OSA person is in his daytime work, whether the person has taken any alcohol or any other sedative medication. So all these are factors which changes the dynamics or the pressure of the pharyngeal airway closure. So different pressure is ideally needed with every breath. So that is provided by these automatic devices. But one thing has to be kept in mind, that this is not a one solution fits all, because there can be patients of COPD, there can be patients with certain restrictive lung diseases, there can be patients with certain cardiovascular diseases who are very like in whom APAP is kind of contraindicated, because the machine will sense that oxygen levels are, like the pressure is low, and they will keep on pushing, whereas the full pressure cannot ever be achieved in those particular subset of patients because of their primary pathology in the lung or the heart. There's something again called the bi-level airway pressure, which gives one pressure level while the person is inspiring, and another pressure level when the person is expiring. So there are two pressure sets for every breath cycle instead of one pressure set as in the auto CPAP machine. And this changes, like this is what has how it can be given. There's something called auto BiPAP, which is not shown here, which now does the same thing but for each every successive breath of the patient. So it varies the pressure, the inspiration pressure and the expiration pressure with every successive breath. There's also something called adaptive servo ventilation, which not only controls the pressure, it also has the capacity to control the tidal volume of the patient. So these are actually often used in patients with the lung or cardiac pathologies associated with OSA, as I was mentioned, in whom APAP should be not be given directly. So this is just how the devices looks like. I had already described all these things. Okay, so there are certain patients who will benefit from APAP therapy. That is fine. So bi-level therapy I had described. Okay. Now there is something called auto-adjusting EPAP with fixed pressure support. I think I should describe a little bit on that, because often it happens that the person has no lung or cardiac morbidity, but the OSA is so severe, or the upper airway edema, or fat is so much higher side that a lot of pressure is needed to open the airway. Often the pressure goes higher on the 15, 16, 17, 18 centimeter of water, which is very uncomfortable to breathe out against. Like while breathing in, it is all right, but when the person is breathing out against that 17 centimeter of water pressure is very difficult. So one, of course, auto BiPAP is a very good option, but another comparatively cheaper option is auto adjusting EPAP, that is expiratory positive airway pressure with fixed pressure support. That is, pressure support means the difference between the inspiratory pressure and the expiratory pressure. So what basically this machine does is that, suppose the person takes 12 centimeter of pressure, needs 12 centimeter of water pressure while inspiration. So it will have a fixed pressure support, let us say 6. And now when the person is breathing out, the person will breathe out against a pressure of say 12 minus, there is 6 centimeter of water. So basically the person's, while the person is breathing in at a higher pressure, like higher pressure is given when the person is breathing in, when the person is breathing out, the pressure is much decreased, so that the person, it is much easier for the person to breathe out against that kind of airflow. So this is a very important tool which is often used in patients who have very severe OSA. Adaptive servo ventilation already described. So now we had discussed about the machine and how the pressure is given. Now we have to discuss about the interface as to how the pressure is given into the human body. So there are various different types of interface, which is called as the masks. It can be simple nasal cannula. It can be something these are called nasal prongs. Basically, these are cannula-like things which are put into the person's nostrils, and the air is put into this. There's something, then this is called a nasal mask, where this covers the entire nose area. There's something called oronasal mask, which encloses the nasal and the oral aspect of the person. They are erroneously called as full face mask in the Indian context, but actually full face mask looks like this. It covers the entire face. And this is something called a chin strap. It is often given to increase the compliance to CPAP, or to improve adherence, because in some patients the mouth opens and a lot of leakage happens. In those cases, chin straps are used. So it is very important to match the right product to right sleep disorder breathing or obstructive sleep apnea patient diagnosis, because there is no one size fits all. It's never like you just get a person, okay, this person has a high HI, so this person has an OSA, so you give him a CPAP machine. It's never so simple like that. There are actually lots of intricacies and details which needs to be modified and cross matched with each particular patient, and it's actually you need to learn a little bit about all these. And take home message is that it is important to use the lowest possible pressure that will keep the airway open during sleep. This pressure is determined by titration. Titration is performed in the lab, like called like manual titration. It can also be done automatically in the lab or at home. A different pressure may be needed for different positions or different levels of sleep. Typically, laying back on the sleep and REM sleep promote the worst OSA, and the lowest pressure that controls obstructive sleep apnea in all positions and sleep levels is prescribed. So, so now we had diagnosed the patient, we had done the sleep study, we had read the report, we had asked the patient to go for a titration, and we had given the person a CPAP. Now, what does CPAP do? CPAP decreases the daytime and nighttime blood pressure, it improves heart function in heart failure patients, improves quality of life, it decreases cardiovascular events, it improves sleepiness and cognitive function, decreases the incidence of motor vehicle crashes, it improves the depressive symptoms, improves diabetic control. So basically, CPAP improves all the consequences of OSA that had been discussed by Dr. Praveen. So basically, it's like a gold standard treatment that is given to patients routinely all over the world for OSA. But there are a large chunk of patients who need some surgical interventions, sometimes in addition to CPAP therapy, sometimes without CPAP therapy, because there are certain patients in whom CPAP cannot be given. There are certain patients who do not like to have a CPAP or find it very cumbersome or discomfort. They are not very comfortable with that. And there are certain some patients on whom there are some compliance issues which can be corrected with minor surgical procedures. So to elaborate all these, I would had like to hand over the presentation to Dr. Uttam Agarwal, consultant sleep surgeon. Thank you so much.
Thank you,
Thank
Dr.
you,
Saurav
Dr.
Das.
Saurav. Yeah. So I think Dr. Uttam Agarwal can carry on with the surgical management.
Yeah, I will be a little brief. Thank you for having me. I think with the allotted time, I will not skip more than 10-15 minutes. Let me just share my screen. Can you see my screen? Am I audible?
Yes.
Yeah, yes, you are audible.
Okay, and can you see my screen?
Yeah.
Okay. So, very good evening, and thank you for having me. I'm Dr. Uttam Agarwal from Calcutta. My topic for today is surgical management. So I will skip all the basic slides, which has been extensively covered by Dr. Yadav and Dr. Saurav Das. Just a point here, when you take a history, you must take a history from the companion person also, maybe it a wife, husband, or a parent, because at times the patient will not come up with the correct nighttime history. And the stop bank questionnaire has been said by Dr. Yadav. And when we add the stop bank questionnaire with the morphometric data like a lateral cephalogram, the sensitivity and the specificity both increases to almost 90 to 100%. So this basic evaluation in the OPD helps a lot in catching the suspected OSA patient. So when we examine OSA patients, so we have to look broadly into two parts: the global issue of the patient and the local. So what do I mean by global issues? So we have to see the weight, how much is the body weight, adipose tissue in the tongue, the neck, whether the patient is very chubby, and we have to look for the local anatomical variations. So we have to look in deep about the nose, the adenoid hypertrophy, tonsils, palate, whether the patient has got any micropnethia, and maximum time what we see is basically an overlap between different anatomical structures. So these are some static obstructions which we can easily see when we ask the patient to open the mouth. The tonsils are pretty enlarged. It's almost like grade 3 to grade 4. And in almost all the patients, we pass an endoscope through the nose to see whether the patient has got any polyps or deviated septum, turbinate hypertrophy, and we look into the nasopharynx. And we are not surprised to see a lot of adenoid hypertrophy even in adults. And we pass a laryngoscope to the patient's mouth, and we see the oropharynx, the hypopharynx, the vallicula, and things like that. The only structure which we find it difficult to assess clinically is a dynamic obstruction. So these are the obstruction what we see when the patient actually goes into sleep. So a normal, very healthy looking palate sometimes may go into relaxation when the patient sleeps, and it may just fall back to the posterior pharyngeal wall, giving it a kind of blockage. So these are the obstructions which are difficult to identify clinically, and to catch this patient, the dynamic obstructions, we need to do some investigations where we can see when the patient goes into apnea, which are the structures which are actually collapsing. So it may be a palate, it may be a tongue, it may be a lateral pharyngeal wall, which may be hypertrophied, and at times it may be even a salpingopharyngeal folds, the epiglottis, even the laryngeal sometimes. So the investigation has been covered extensively by Dr. Saurabh. So what I will say is basically the evaluation of the site of obstruction. So by PSD, we know whether the patient is suffering from obstructive sleep apnea or not.
Hello.
So level 3 is being reserved for patient who has, when we have only suspicion with no medical comorbid condition or other sleep disorders. And we suggest usually a level 1 study when the patient has got some medical comorbid conditions, or we are suspecting some other sleep disorders apart from OSA. So once we are through this, we ask the patient to undergo either a sleep endoscopy or sleep MRI or dynamic MRI. My choice is basically a sleep endoscopy or a DIAS, what we call it as a drug-induced sleep endoscopy. There are a lot of modifications now has been added to DIAS, where we do an advanced DIAS with a bispectral index monitor along with the polysomnography to be very pinpoint. When the patient is going into apnea, we can see what structures are actually going into apnea, which structures are falling, giving to blocked airway. Sometimes we even do an interventional DIAS where we put a nasal airway and we try to relieve the upper part of the blockage, the nose part of the blockage, and we see many times the lower part of the blockage also goes off. So it's basically a kind of cascade, where one thing falls just to other thing also collapsing. And we do with the different maneuvers where we do a jaw thrust or chin pull and other procedures to add up to the drug-induced sleep endoscopy. So our motto of investigations for any patients who are supposed to go for a surgery, whom we recommend a surgery, has to undergo a DIAS. So a DIAS is something, why we do it. The PSD can tell us about the urgency of the surgery. When we see LSAT is very low, around 40-50%, and when the AHI is very high, that only tell us about the urgency of the surgery, and it will not tell us about the obstruction or the anatomy of the upper airway before surgery. So we base something on DIAS, where we know the complete dynamic assessment of the airway during sleep. So what is DIAS basically? DIAS is basically a drug-induced sleep endoscopy done in an OT setup with all the emergency stuff ready. Endotracheal tube, LMA should be very handy. We do with the BIS monitor. The anesthetist start giving medicine in very slow, small titrated doses. They start with either a propofol or a dexmedetomidine along with the midazolam, and we keep on monitoring with the BIS score. We never go beyond 60. So we try to keep the BIS score between 60 and 70. Below 60, the patient is usually basically going into anesthesia. We want to avoid that. So we keep our BIS score above 60 to 70, and the LSAT, we never cross the LSAT what has been said in the polysomnography. So at one time we are monitoring the pulse oximeter. We never want to go beyond the lower saturation what the patient has normally encountered during his or her regular sleep. And at the same time, we keep the BIS between 60 and 70, where the patient is into sedation but not going into anesthesia. So based on that, we look for the pattern of the collapse, how the airway is collapsing, whether it is an anterior posterior collapse, or whether it is a lateral collapse, or whether it is a circumferential collapse. And we also see for the degree of the collapse, whether it is only a partial or a complete collapse. Based on that, we give them a scoring called a VOTE classification, where the V stand for the velum, oropharynx, tongue, and the epiglottis. Based on the VOTE classification, we design our surgery. So a DIAS is something like ECG to a cardiologist, or a USG or CT to GI systems, GI surgeons. So we rely a lot on our DIAS findings. So these are some patients where we have done the DIAS. You can see here. This is basically a turbinate, the inferior turbinate. Here is the septum. The patient has gone into snoring, and then we pass the endoscope and we negotiate our endoscope through the structures. Here we see we are facing some difficulty in passing our endoscope because of the DNS. We try from the other side. There are some mucin. So that means the patient has got some allergic features also. The nasopharynx is very congested. which suggests the patient has got some allergy or maybe a GERD also. This is the palate, which is almost like completely falling onto the posterior pharyngeal wall, giving it almost like a complete collapse, but in a anterior-posterior direction. So what we have seen in this patient's diasis, the patient has got a nasal issues, patient has got a DNS with a turbinate hypertrophy, and he has got a palate which is falling anterior to posteriorly. So this helps us a lot while we design the surgery. We tailor-made the surgery for each patient. So depending on what we are getting on the dais. So this is the epiglottis. This is the epiglottis. This is the larynx. And we see even the tongue base has got some adenoid hypertrophy, some adipose hypertrophy, some lingual tonsils, and the airway is otherwise fine. Similarly, if we see another dais where we see some other cause, here we see the nose is pretty roomy. The septum is pretty all right. The turbinates are pretty all right. The escutcheon tube is little on the bulkier side. This is the palate again, the soft palate, the velum area, and this is the uvula. Still, there is some space where my endoscope can be negotiated deep down into the oropharynx and the hypopharynx. This is the airway, and this is the epiglottis. So as the patient goes into apnea, see how the epiglottis is completely covering the glottis area. So this is basically a kind of primary epiglottis collapse, where the epiglottis completely covers the airway, giving the patient a apnea episodes. So these are the classical patients where even the CPAP will fail, because the CPAP will not be able to deliver the required amount of air or pressure air into the lower airway. So this is very important from a surgeon's point of view, what kind of collapse we are getting. And at times we get multi-level collapse. So when we pass the endoscope, we see even a lot of mucins. So the patient has got some allergy, some turbinate hypertrophy. Patient has got also a deviated septum. The salpingo folds on both the sides are pretty hypertrophied. And we see it's almost like a concentric collapse at the level of velum. So this is the palate, this is the salpingo fold, this is the nasopharynx. And so the area from the velum to the oropharynx is almost like, completely you're getting a circumferential block. And as we go deeper down into the oropharynx, see here, it's almost like a concentric collapse at the level of velum. And as we go deeper down into the oropharynx, we see even tonsil hypertrophy giving a collapse at the level of oropharynx also. So this is basically a multi-level collapse where the nose, the palate, and even the tonsils are responsible for the upper airway blockers. So treatment options, once we know the patient has got a apnea, moderate or severe, when we know the type of collapse the patient is having and the degree of collapse that the patient having, the structures which are involved in this collapse, then we can plan our surgery. The lifestyle modification, weight loss, oral appliances, and PEP3 has been covered by Dr. Saurabh Das. I will be very brief on the surgery part of it. So broadly, the first choice, whatever a patient has got in terms of sleep apnea, we always give a patient a CPAP trial, and we look for the compliance, the improvement in AHI, the quality of life, the amount of leak the patient is having, and the average percentile pressure of the airway. If the patient is compliant with all the issues, we continue with the CPAP. It's only when the patient is uncompliant, we go for the surgery. And surgery we normally divide into either a soft tissue surgery, and we reserve the skeletal or the out of framework surgery for the severe OSA who are not getting benefit with the soft tissue surgeries. So here are the few examples of the patients where CPAP was tried and it failed due to some structural reasons. So this gentleman walked into the clinic. He's almost like dozing off talking to me. He almost went into sleep while talking, and definitely there was something wrong with this patient's airway. And this patient has diagnosed OSA, and he has been given CPAP by many previous physicians. And when I pass the endoscope, this is what I see. The epiglottis completely rolled up upon the glottis. There's hardly any view of the glottis here. And when the endoscope was negotiated, we can see a small glimpse of the airway. These are some ulcerated area on the piriform fossa. A little closer view has shown, the airway completely blocked by the epiglottis. The vocal cords are almost immobile, and with the patch on a detailed history, we came to know the patient has got a piriform fossa CA, for which he underwent radiotherapy. And after radiotherapy, this is what happened to the epiglottis, and made a patient from non-apneic to a completely severe apneic, which failed CPAP therapy. And the patient was advised tracheostomy immediately, and further evaluation for the ulceration, and the quality of life tremendously improved. And we managed to, survive this patient with the help of surgery. This is a second example where a middle-aged gentleman presented with complaints of severe snoring, excessive daytime sleepiness, tiredness, and lethargy, but there was no complaints of swallowing disorder or breathing difficulty, neither any change in voice. Again, he was again seen by already diagnosed case of OSA, seen by many physicians, given a CPAP. He was not tolerating CPAP at all, and he says on using CPAP, his symptoms aggravated, or there was more of choking sensation during use of CPAP. And when we pass the endoscope, this is basically on the table itself. When we pass the endoscope and we see a huge ball, this is a valvular cyst in the valvula, which is completely obliterating the oropharynx, the lower hypopharynx, and the laryngeal area. So when we negotiated our scope deep down, we can see the airway, which was quite patent. So this patient has an apnea because of this valvular cyst, and we managed this patient with a simple valvular cyst excision, and even a CPAP was not required in future treatment. This is an example of a third patient where a patient presented with a known diagnosed case of sleep apnea, diagnosed somewhere else. He was given a CPAP trial. He didn't tolerate it well, and he said he feels suffocated whenever he used the CPAP, and even his time taking for CPAP trial was only 2 hours because that device was very uncomfortable for him. And on the basic ENT examinations, there was only a DNS with a hypertrophic turbinate, a thick palate, and otherwise he was otherwise absolutely normal. So there was no mass lesion, there was nothing. So we asked the patient to go for a drug-induced sleep endoscopy to know what exactly is happening. So this is a patient who is lying on the bed, preparing for the drug-induced sleep apnea. We can see the patient is going into apnea now. The patient has been given the drug, and there is a paradoxical movement of his, thorax and the abdomen. The patient is going into apnea, and we keep a small, very close watch to his monitor, and we make sure his saturation doesn't fall below. And this is what we see in his diet. So when we pass the endoscopy to his nose, nostril, oropharynx, and this is what we came across. This patient has got basically a primary epiglottic collapse. So here the epiglottis is completely, covering the laryngeal part and making him completely choke. So these are the patients who will not do well with the CPAP also, and that needs some kind of surgical evaluation to make them all right. So the causes of CPAP failure, in my knowledge, is basically a structural reasons. Every patient who fails CPAP must undergo a nasal endoscopy and a laryngoscopy to rule out any structural causes. Sometimes the patient may have some other sleep-related disorders. The EDS may be for some other disease like narcolepsy or periodic limb movement syndrome. And at times the patient do not tolerate the CPAP because of claustrophobia or very poor convenience. So can we ENT surgeon play some role here? And my answer would be certainly yes. And not only in some patients, what we have shown now, it can have a direct impact where even no further treatment is required, neither with CPAP or the other further surgery, when we remove the blocked surgical part, structural blockage. But at times, even when we do a multi-level sleep surgery, it makes a CPAP uncompliant patient to a compliant. When we remove the structural blockage, it improves the compliance of the CPAP. So many times the surgery has been done to improve the compliance, and at times it is self-sufficient for the patient to undergo the surgery and become all right. So the previous concept of ENT surgeon in OSA management was a little lacking. We do not have the much information of the polysomnography. The understanding of the PSG was very little to us. We never used to give importance to global factors like very high BMI and obese patient. And our concentration and target was mainly palate, and maximum time the surgeon used to end up doing a UPPP or ovulopalatopharyngoplasty, and there was no evaluation for the site of obstruction. But with the now current approach, we are reading PSG like our sleep medicine colleagues, and we assess the upper airway thoroughly, either with a rigid endoscopy or with a DIAS, and we see the level of obstruction, the structural which are involved into the obstruction, the pattern, the severity, and we are moving from more ablative to a minimally invasive surgeries. So depending on that, the treatment is planned, the treatment is being discussed with the patient and his families, depending on his comorbid condition, the age, and we as a surgeon look at the pharyngeal anatomy, both rigid, structural, static, and also a dynamic anatomy of the airway with the help of DIAS. So the basic principle in our surgeries, the key to surgical success in OSA is the patient selection. We have to be very choosy when we select the patient for the surgery. because surgery is not a complete solution for the all OSA patient, and patient has to be completely, wisely chosen up. And second is the procedure selection, or what procedure we are going to do. So depending on the children, where it is the adenoid and tonsillar hypertrophy which causes most of the problem, and at times it may be because of the craniofacial abnormalities. In adults, what we see, it is usually a multi-level obstruction. It is never a single obstruction, and we see some degree of obstruction at the level of nose, nasopharynx, velum, super combined with the tonsil hypertrophy, palate lax, palate bulky, or even a tongue bulkiness, or tongue fall, or epiglottic fall. So in adults, we end up doing maximum time a multi-level surgery, and in children, maximum time we end up doing a adenotonsillectomy. So this is a very brief, surgical steps of surgery for children. This is uvula, this is soft palate, this is tonsil. We use a magic wand called coablator. This is a device which makes the surgery almost bloodless. It has got the power of suction. It has got the power of ablation. It has got a power of coagulation. It also gives some saline into the tissues to damage the thermal injury. And the procedure is done almost bloodless, and the time taking is very, very minimal. So with the advent of coablator, our surgical time has been reduced for almost for a case of tonsillectomy to almost like 8 to 10 minutes, and we can finish the tonsil almost bloodless, and the patient can go home almost same day. Even for small children, we are doing it. My youngest child is just 2 years old, where we have done this procedure, and it is almost bloodless. Same way for the adenoid, as we see, this is basically a tonsillar part, and as we see, this is adenoid, this is a septum, this is a turbinate, and the adenoid is pretty hypertrophic, completely blocking the airway. And again, this coablator wand, which has been introduced from the mouth, and as we place our paddle, and the energy has been discharged to tissue, we start ablating, and within a matter of few minutes, the thing will disappear, and the nasopharynx will completely clear up. And this is how it looks, at the end of the surgery. So this is basically in the cases of children. In adults, we usually give a lot of importance to the nasal surgery, because this is the first point of nasal resistance. Not only it helps to eliminate the nasal obstruction, but it also reduces the severity, and it facilitates the other treatment modalities. So this, so apart from the septum surgery, we always make a note about the turbinates. So along with the septoplasty, if there is any polyps, we remove that. And we attend turbinates by different ways. Either we can use a coablator to reduce the turbinate. We can use the radio frequency blade to minimize it, to reduce the size. And here in this video, I'm removing the part of the concha bullosa, which is the part of a bulky middle turbinate, to give it a little room into the middle meatus. So these are the different turbinate procedure what we do in the nose, along with the septoplasty, to make the nose roomy. Nose is one of the most pivotal in treatment of sleep surgery, and whatever procedure we do, we make sure the nose is open, and we do not want any kind of resistance in the nose when we are treating a patient with sleep apnea. So once this is done, we decide on the palate depending on the DICE finding. Earlier, a lot of importance was given to pillar implants and cautery assisted ovuloplasty, but now they are no more in vogue. So depending on whether we are having a tonsils or we are having without tonsils, and the pattern of collapse. So whether it is a anterior posterior collapse, or whether it is a lateral collapse, or whether it is a circumferential collapse, we choose our surgery. It can be an anterior palatoplasty for an AP collapse, and it can be an ESP or expansion sphincter pharyngoplasty in case of a lateral collapse, and it can be a combination of both our procedures in case of a circumferential collapse. At times, we end up doing a geta-pharyngoplasty. I will come to that. Where it relieves the blockage at the level of palate circumferentially. So this is basically a palatal procedure done maybe around 8 or 10 years back. So the tonsillectomy has been done. This is a part of the mucosa of the anterior pillar which will be removed, and this palatopharyngeal muscle will be pulled up and will be stitched up to the anterior pillar there. So this is how the anterior pillar is being removed. We take a thread, we put a tie on the palatopharyngeal muscle, and we start pulling the muscle up to the level of anterior pillar, and we tie it up. And this is how the whole of the lateral wall opens up, and you see the uvula is pointed up. So similarly, we do the same procedure on the other side, and at the end of the procedure, we remove the part of the bulky uvula, and we just approximate the raw margins. Same way we can do an anterior palatoplasty. I don't have the videos for this right now. So where we remove a part of the mucosa and the minor salivary gland, and we stitch this tissue back up. It's just a 10 minutes procedure, and it's that increases the anterior posterior dimension of the pharyngeal wall. Same way for the for a lateral collapse, after a tonsillectomy has been done, the palatopharyngeal muscle has been exposed, and we take a suture and we move this muscle submucosally, and we tie up superomedially, thus increasing the. So here we see the lateral lateral wall from here to here, and this is completely widened up once we have done this procedure. Same way the jeta, we we denude this mucosa after the tonsillectomy. We denude the mucosa in a butterfly fashion, and the lower tissue are being exposed. We split the uvula and the soft palate up to the dimple area, and we suture it back to the raw area. This helps to open the lateral AP in all the dimensions, and this gives a wonderful, perfect result post surgery. So coming back to the next, tongue base. Why do we treat the tongue base? So in patients who has got a severe OSA are more likely to have a tongue base collapse, and the patient who have failed the previous surgery of the soft tissue of the palate may need some kind of tongue base procedures. I will not go into very detail after technical things. So these are some of the procedures what we do for the tongue base. It may be a genioglossus advancement with mandibulotomy, hyoid myotomy, tongue suspension, either with the use of radio frequency. We can use channeling or tissue volumetric reduction, or minimal submucosally glossectomy. So these are some blades which we are pointing to the tongue base. We are shooting the energy, and this thing will completely collapse. Or this is with the help of a coplator blade, where we do a midline glossectomy. So important concepts in the sleep surgery, we have to be very choosy with the patient, and we have to be equally choosy with the procedure. We should understand the basic concept of container versus contents. So our jaw is basically a container. How big is the container? How much is the content inside in terms of tongue bulkiness or a tonsil bulkiness or a palatal hypertrophy? In all surgeries, the nose is pivotal but not primary, and we need to correct the nose in almost all surgical patients who need a multi-level sleep surgeries. Airway evaluation is very crucial, and as we have seen in many patients, we can avoid the further surgery by simply correcting the basic structural obstructions. Palatal surgery, UPP was there in the past, a very ablative surgery, but now we are moving more towards the reconstructive surgery, and tongue-based surgery is crucial in success criteria. So this is now what we don't do. So this is not what we do. So what we chop whatever comes into our way. This is not what we do now. We don't chop whatever comes into our way. We assess the complete scenario, and we tailor-make the surgery. And the sleep medicine, the sleep science is going to this. This is Demon, the sleep apnea, and a single superhero is not going to stop this demon from us. We need a complete team evaluation, a complete team approach, has been said by Dr. Yadav. So even a most powerful surgeon or a sleep physician may not be able to stop this demon from hurting us, and we need a complete help from different our specialties, our dental colleagues, the maxillofacial, the CPAP specialist, the chest physician, neurologist, cardiologist, to stop this. And this is our take-home message. This is a multidisciplinary subject wherein ENT evaluation is a must for the holistic approach. Surgery is indicated for selected patients and patients who are uncompliant to CPAP and dental devices. The static obstructions leads to uncompliant CPAP and should always be addressed to make patient use of CPAP more compliant. And multi-level surgery works well in selected patients. And thank you so much for your time and patience hearing. Thank you.
Thank you for the excellent talk, Dr. Uttam Agarwal. The videos were very good, and it was a great learning experience for us also. Thank you for the excellent talk, and I thank Dr. Sarodas also for enlightening about the procedure of polysomnography. I think here the awareness of polysomnography and the sleep disorders, obstructive sleep apnea and all is quite less, especially in our state. I think we need further such webinars and programs so that we can create awareness and the importance about the knowledge about obstructive sleep apnea and its impact on various disorders, and also the concept of the team approach, so that we need the entire team of physician, ENT specialist, dental specialist, sleep specialist, pulmonologist, so that everyone can contribute their bit and that so that we can make patients better. So that is the message from our
Very
part here. Yeah. Dr. Saraf, would you like to add anything from your end?
Hello, am I audible?
Yeah, yeah.
Yes, I think it was a very well-planned webinar, by which we attempted to cover the basic topics related to obstructive sleep apnea.
Yeah.
And I think, as both you and Dr. Uttam Agarwal mentioned repeatedly, that it's now time for a team approach where we, as physicians from any specialty that we come into, we have to look at the patient from a holistic point of view and try to find out what is happening there. And we need to take help from our colleagues, regardless of, whether we like, regardless of what we think of that. Earlier it was like I alone will do everything. It is not the case anymore. We have to have a multidisciplinary approach in treating patients of OSA. And I think it will definitely go a long way if we can increase awareness about the subject and about the topic in our state. Thank you, Dr. Praveen, for inviting me.
Yeah, thank you both the speakers, Dr. Uttam and Dr. Saurav, who took out their time on this Sunday evening. And also I thank all the audience who spent their valuable time in a Sunday evening. And also Intas Pharma, who provided us this excellent platform for presentation and the connections. So hopefully we'll have a webinar very soon again for the people who have missed out this time. And so I think we'll call it a day today. And thank you both for joining.
Thank
Anything
you,
else? Yeah. Dr. Uttam, would you add anything else? Just
no, thank you
before
so much for inviting. Thank you so much for the inviting. It was really a good learning from both of you, and it's always great to listen, to subjects related to sleep apnea. And I hope our audience or our viewers have got some take-home messages from our talk, and we hope to have some more talk like this in future also.
Yeah. Okay. Thank you both.
Thank you.
Goodbye. Bye. Take care. Yeah.